Well, for those of you who taking a quick look at the participants in this web conference, I saw that quite a few of you are members of the advisory board. But for those of you who aren't or who are unfamiliar with our organization, I just wanted to say a couple of words. As Aaron pointed out, we're a membership organization that provides research and strategic insights to the healthcare industry. One of the things that we do for our members is we track what's going on in the healthcare industry and what's sort of coming at you from the other side of the horizon, things that maybe you haven't thought of yet or you're not quite aware of yet. The material that I'm going to present today is really a condensed version of the same material that we offer to healthcare CEOs around the U.S. and actually around the world. So I just want to start by thanking you, the folks here at Formfast, for giving me this opportunity to show you the sort of things that we're seeing. And in today's presentation, this material I'm going to show you, you'll see that the healthcare landscape is really undergoing some pretty fundamental transformations. The survival in the new healthcare marketplace is going to require that we do more with less, and we increase standardization and automation, and that the smart, cost-effective use of information technology to enable our business and clinical strategies is no longer something that's optional. It's going to play a critical role in the evolution of what we call the communities of care. And I think you'll see that many of the things that were talked about earlier this morning are going to be very useful and applicable. So I've broken this into two sections. The first section's a lengthy one, spending time reviewing the state of the healthcare industry. And then in the second section, we're going to do a little discussion of the implications of all these changes for IT. So I want to start here with this. You know, probably 10 years ago, we would have thought the data you're seeing on the slide was good news. We'd be talking about how pricing has come back, how spending has come back. We're pulling out of the recession. It's time to start building and investing again. And you know, on the surface, some of those things are actually true today. Spending has come back. The evidence is pretty clear that the healthcare industry is coming out of that recession. The problem is that on a nationwide basis, spending isn't coming back for hospitals. Some of it is accounted for by coverage expansion and increased utilization among the newly insured. But if you look at where the majority of the resurgence is coming from, most of it is coming from the prescription drug side. A lot of it, in fact, is due to specialty drugs, so things like Sovaldi and biosimilars. And if you look at pricing for hospital services in particular, you can see that for the first time, providers are actually starting to lose out on price. We at the advisory board have been talking about the end of price growth for a few years now, but this past January was the first time the recorded price growth actually went negative. Now, price has rebounded ever so slightly since then, and that's apparently due to provider consolidation. But it's clear that steady, predictable, and significant price growth is a thing of the past, and that's something that we've been living on for decades in healthcare. And so the days of living on that price inflation are gone. So let's take a look at some of these market changes, and we'll start with Medicare. Provider consolidation that we've seen to date is not giving us pricing power over Medicare. The Affordable Care Act cuts Medicare reimbursement pretty dramatically. So we're talking here billions of dollars of downward revisions. They call some of these cuts productivity enhancements, but they're happening whether you get more productivity or not. And the results, as you can see here, are pretty drastic. It's not at all unreasonable to expect Medicare pricing to trend towards today's Medicaid levels over the next 10 years. Now, the recent SGR fix isn't really helping either, at least not on the hospital side. About half the funds allocated for or paid to repeal will be taken out of the backs of hospitals in the form of various price cuts. And as we move forward, the administration continues to propose additional reductions. Most recently, they proposed cuts to teaching hospitals and to critical access hospitals, and that's without even mentioning the looming prospect of site-neutral payments, which are going to erode the unique pricing advantage that hospitals have today. But, of course, this isn't just a story in the healthcare marketplace about pricing. It's not just about Medicare. Purchasers of all types are making some pretty tough decisions about how, and not just how much, to pay for healthcare. For its part, the government seems to be doubling down on its strategy of shifting risk to providers. So Medicare and at least some Medicaid programs are really putting a stake in the ground to shift the industry towards population health management, away from fee-for-service. Employers, on the other hand, are increasingly face a decision about whether to stay in the healthcare game at all. And they're trying to respond to a new set of demands under the Accountable Care Act, and they're evaluating a wide range of models for how to deliver health benefits going forward. And consumers, who, let's be honest, have historically been pretty passive bystanders when it comes to the purchasing mechanics in healthcare, that they're taking, or at least they're being forced to take, a more active and financially exposed position. So what I mean by that is high deductible plans and large co-shares. This has led to more and more Americans making their own decisions about how they want to consume health care and who they want to obtain that care from. And these trends now, they're not unrelated, but they're not exactly cohesive either. So if we were going to craft a reliable strategy for tomorrow's market, we need to understand how these seemingly different threads fit together. So what I want to do now is take a closer look at each of these purchaser groups and see how their motivations and behaviors are shifting and what those changes mean for provider organizations. So let's start with Medicare. And you all know that Medicare is our single largest payer, and it's only getting bigger with time. And there's no longer any doubt about the direction that Medicare is going. Medicare is absolutely moving to population health. Now, that's been a general sense for a while, but now we've got a specific statement of intent. Health and Human Resources has announced a goal for half of all Medicare payments to be in the form of alternative payments like bundled payment, shared savings, or capitation by 2018. That's just 3 years away. And a full 90% of any remaining fee-for-service Medicare payments are to be transitioned to pay-for-performance models during that same time frame. That's a really big shift, and it's not going to come easy. But CMS seems to be pulling out all the stops to move in that direction. Now, let's not forget the absolutely mandatory payment reforms affecting all acute care hospitals. So the hospital value-based purchasing program, the readmissions reduction program, and the hospital acquired conditions reduction program. A lot has been made of the potential for these programs to earn bonuses through value-based purchasing. As a reminder, the value-based purchasing program was intended to be budget neutral. The government takes money away from the bottom half and gives it to the top half. That's how it works, at least in theory, and that's pretty much how it seems to have shaken out in practice. This year, about half of the hospitals earned a bonus, while about half were penalized. Now, that may not sound all that terrifying, but it's a great opportunity, at least for half of you. The problem is that when you consider all of the pay-for-performance programs at an aggregate level, and you layer the readmission penalties and the HAC penalties on top of the value-based purchasing program, you'll see that most hospitals actually lost money at the end of the day, because the readmissions in the hospital-acquired conditions program are downside only. So about 75% of hospitals ended up with a net negative. What that means is that pay for performance is essentially a pay cut. It's a pay cut that only scales as the program gets bigger and bigger, and it means that doing more with less, cutting costs and optimizing your performance with the resources you have is really going to be the order of the day. Now, CMS has also proposed expanding bundled payments, the bundled payment program. It's called the Comprehensive Care for Joint Replacement model. And currently, the average expenditures are double in the most expensive areas compared to the least expensive areas. Now, you should also note that the program is proposed to be comprehensive for the entire episode and is mandatory in 75 different markets now. Of course, this is just another way to move away from fee-for-service payments to risk-based payments. So that's only one payer, and we're already talking about a lot of change and a lot of options. When you lay it all out, you can see how CMS is really starting to fill in the gaps on the continuum towards greater and greater risk for provider organizations. With mandatory pay-for-performance and programs like the Readmissions Reduction Act, all providers are now essentially de facto at-risk Medicare for Medicare dollars. For those providers looking to dip a toe into the risk without really diving in all the way, bundle payments and Track 1 of the Medicare Shared Savings Program provide a way to experiment and build out your necessary infrastructure. Track 2 and the new so-called Pioneer-like Track 3 incentivize pioneers to begin the transition towards downside risk. And the next generation accountable care organization and Medicare Advantage plans provide full risk options for those who are even further down the line. Basically, the message here for Medicare is really clear. Fewer dollars, more risk. In other words, you'd better perform if you want to get paid. So at a high level, let's talk about employers now. We see employers are going in one of these three directions. So first, there's the activist strategy, and these are employers who need or who want to stay in the health benefits game, to stay competitive in the labor market. But they're going to be very hands-on purchasers, and they're going to pay a lot of attention to what they're buying from provider organizations. And then there's the second bucket of employers who are happy to continue providing health care but don't really want to get too involved in the process. So this is the employer who would rather delegate responsibility to someone else. So outsourcing health care benefits to a third party, placing more of the decision-making burden on the employee. Private exchanges, not the public exchanges that you hear about in the press all the time, but the private exchanges are probably the best reflection of that kind of approach. And then there's this third category of employers who just want to drop coverage altogether, and that's the public exchange route. So now that we've got public exchanges, that's an option. It's for employees and employers. We started to refer to them as abdicators. So there's a lot about the possibility of huge numbers of employers pursuing this strategy, but in practice, what we've seen is that this group is pretty small. So for the purposes of our discussion, I'm going to focus primarily on those first two strategies. The active approach takes a lot of different forms, and some employers are following the government's lead, and they're placing bets on care coordination, on care management, and integrated networks. They're attracted to, or at least open to, the idea of one-stop shopping solutions. So exclusive or maybe narrow network arrangements with a comprehensive population health manager. We saw some early moves into doing this. So Intel is Presbyterian in New Mexico, and Oregon, Kaiser in Providence, also in Oregon, Boeing in Washington State, with Providence and Swedish as major participants, University of Washington. But we really haven't seen this catch on. While we've seen those organizations set a toe in the water, it hasn't caught fire. Others are focusing more on smart choices at the point of care instead of the wholesale decisions about network design that these employer-based ACOs represent. So instead of choosing a preferred provider, what this group would would rather do is maintain their open networks and find ways to steer their employees to the highest value providers in that menu. And you notice what this approach does is to unbundle the comprehensive value propositions that systems who pitch exclusive contracts are making. It's essentially rejecting wholesale value in favor of retail choice. And we're seeing some employers enlist the services of independent referral services as well. These services limit or narrow the referral options within a health system, and they divert the volumes to other providers who are outside the health systems and perceived to be of higher value. Basically, this has several implications for providers. So number one, lower volumes, and number two, tougher care management, since the patients are going to be out of your network. Again, the message here is you'd better be prepared to perform if you want to be in that slice that gets chosen. And here's an example. This is essentially the Centers of Excellence kind of approach here. The organization we're highlighting here is called Bridge Health. And although there are a number of different players we could have profiled, Bridge Health is just one example. They layer a select set of high-value surgery providers on top of an existing open network plan. An employer can keep its network just as broad as it was before, but for certain procedures, Bridge encourages patients to use those carved-out providers. Some tools are sort of gentle nudges, like a web portal that explains what your options are to the employee and the patient. Other times, the encouragement is a lot harder to ignore. So in many cases, patients' out-of-pocket cost is $0 as long as they use the selected provider. Now notice that participation in these networks is contingent on performance at the procedural level. So a hospital that Bridge might carve out for cardiovascular surgery wouldn't necessarily be the preferred provider for orthopedics if it couldn't deliver on the same level of quality. So Bridge basically helps employers identify the best of the best within the markets across facility and across system lines. Narrower networks are another lever, a lever that insurers, payers can pull to offer more competitive premiums in a price-sensitive market. The other major lever available to them is benefit design, and the more out-of-pocket cost a consumer is willing to take on, the lower the upfront cost is going to be for the benefit. So the higher the deductible, in other words, the lower the premium. And in fact, benefit design is the main factor that differentiates between the metal tiers on the public and private exchanges, so gold, silver, bronze. You may have heard about those. The fact that most enrollees continue to choose bronze and silver plans tells us that the majority of enrollees are choosing high deductibles. So looking at the bar graphs on the right, we see that fewer people chose deductibles over $6,000, and also that fewer people opted for plans with deductibles less than $1,000. So it's a little bit scary to see that 2/3 of the people selected deductibles of $3,000 or greater. And now you have to see this in the context that between 30 and 40% of workers over the age of 45 have a net savings and investment of less than $10,000. So basically, they're at risk for 1/3 of their entire savings. At least that's according to Forbes. So, you know, think about that. Your personal safety net is less than $10,000, but your health plan has an annual deductible of $3,000. One hospitalization can easily wipe out your savings. And yet, so far, satisfaction with the narrow networks and the high deductible plans has been pretty good. That could be because people haven't really had to use them very much yet. The problem with these plans, of course, is that a lot of consumers don't have the cash on hand to cover those deductible levels. So a couple of big implications are here for providers. So first is the possibility that people are going to stop consuming care. Obviously, this is a huge problem for an industry that's trying to move towards population health. Another thing that happens, though, is that consumers become much more price sensitive. And the first thing they do when they need care is to jump online and try to figure out how much it's actually going to cost them. The evidence is pretty strong that an increasing number of patients are trying to solicit pricing information, and those numbers track directly with deductible levels. So the higher the deductible, the more likely it is that the consumer at some point has tried to find pricing information. And so the only way that insurers are going to be able to keep premium growth low if the medical expense trend is low. So payers are going to seek to drive down the medical expense trend. And I think really this is the biggest unknown in the marketplace right now. In theory, the competition inherent in the exchange setting should incentivize insurers to innovate on network design and to invest in care management and otherwise find ways to keep the cost trend down and premium growth low. But in the early days, what we've seen is at least some of the private exchange operators have put safeguards in place that actually limited the amount of competition in the exchanges. They did this in an effort to encourage payer participation to avoid tipping the scales in favor of one particular payer, and it's led to some difficulties. So, for example, one of the biggest complaints we've heard from the employers we spoke to is that the networks on the private exchanges today are almost universally broad, unlike the public exchanges. Private exchanges have not pulled the network assembly lever as a way to control costs yet. This is bad news for providers. There isn't much room for regional networks on the exchanges today, and that's starting to change, and I think it will have to change if the private exchanges are ever going to truly deliver on the value proposition. So just trying to sum up here, there's really no denying that the world is one of increasing complexity, and that provider organizations are facing really a cacophony of cost-saving, risk-shifting, performance-managing strategies from all different stakeholders who are buying your services. You've got the world of the government pushing towards population health and risk, and that's a path that we all have to go down given how much business we do with Medicare. And then you have employers who are budgeting health care any way they can, contracting with an ACO in some cases, like we've seen with Boeing or Intel, but more often than not, picking you apart and transitioning to a consumer-driven kind of strategy. And consumers are demonstrating that even health care has a price. They're purchasing higher deductible plans, and they're shopping around for care, and they're trading narrow networks for lower premium. The challenge providers face today is how to sort through all this noise. And again, this touches that bell about you'd better perform if you're going to succeed in the new marketplace. So despite all the pressures to cut costs, most provider organizations couldn't afford to slash prices across the board even if they wanted to. And this is because they have big facilities that they have to support, an extremely high fixed cost base that they have to cross-subsidize. What that means is that to the extent that you're going to be higher priced than some maybe nimbler, leaner competitors, you have to find a way to, they have to find a way to justify premium pricing. You have to find a way to justify premium pricing. The advent of consumerism doesn't need to result in the complete commoditization of healthcare. You need to find ways to differentiate on other factors like location, wait times, clinical quality, service experience. So when I say you better perform, I'm not talking just about perform on price and cost. I'm talking here about the whole experience. So in other words, you got to find ways to broaden the conversation and make it more about more than just price. And so now I want to shift gears here and talk about what provider organizations are doing in response to this marketplace. And as you can see here at the top of the slide, we're in the midst of this transition I've been talking about from volume-based care, where we manage through encounters and get paid on a fee-for-service basis, to episodic-based care, where we start to focus on value and risk, and then ultimately to a world of care management across populations and across the entire course of a patient's life, not just dealing with the snapshots of their lives that we have under the encounter-based care model. As the industry undergoes this shift, what we're seeing is organizations are forced to change and evolve as well. So the holding company model, where there's a lot of local autonomy, works fine for the encounter-based care and the fee-for-service model. As we move into the world of risk and episode management, we realize that we need to transform into a more centrally run, standardized operating company. And ultimately, we're being challenged to move even beyond that to virtually integrated enterprises, where we incorporate partners and affiliates that we don't own into the basic care equation. Bottom line here is that if you were to try to create an operating company that incorporated all of the providers in your community, you just couldn't do it. So you have to find ways to partner effectively with those ones that you can't buy. And as I say, this movement is what's been mainly driving consolidation. So mergers and acquisitions and partnerships and affiliations among providers. You're trying to defend yourself against increasing pricing pressures and create organizations that are also more competitive on quality and service. We see a lot of provider organizations dealing with this transition from holding company to operating company. And we also see some dealing with the transition from operating company to virtually integrated enterprise. But honestly, when I look at what's going on in the marketplace and I talk to organizations throughout the U.S., most of you are dealing with both transitions at the same time. Now, if you look at the bottom of the boxes here, you can see that these changes also manifest themselves in our IT strategies and architectures. So a best-of-breed approach is well-suited to that holding company model, for example, but the operating company drives towards enterprise suites. So providers are attacking this from multiple angles. So first of all, there's organizing the owned and operated versus organizing your work with partners and affiliates. Another aspect of this topic is vertical integration versus horizontal integration. So by that I mean if you're a hospital acquiring an ambulatory practice, vertical integration, the situation's a little bit different than if you're a hospital acquiring another hospital, or horizontal integration. So I want to start with the discussion about mergers and acquisitions. And let's show you here what's happened in the industry as a result of all this consolidation. There's a lot of numbers on this page, but they add up to one key point. The most significant impact of consolidation has been an increase in prices. Now, we may have told ourselves, as I mentioned earlier, we may have told ourselves going into these arrangements that they were going to lead to improvements in efficiency or quality, but the clearest result in the markets where significant mergers have occurred has been to raise prices to the consumer. Now, I suppose the good news here for hospitals, at least in those markets, is that they've been successful at fending off downward price pressures. The problem, though, is, as I showed you earlier about the movement towards high deductible plans, consumers are liable, and given their financial situation, they may be forced to vote with their feet and look out of area for care. And we're still, a study by Booz & Company, shown here at the bottom, shows that about 20% of these deals seem to have actually damaged the margins of the acquired organizations rather than helped. Now, there's a number of reasons for those results, which I've listed here on the right. So the disruption of strategy, so sometimes both the acquired and the acquiring organization undergo disruption of their strategic efforts. There's very, very often a lack of quality metrics to track progress on improvement goals. There are disruptions to ongoing operations that can set both the acquired and the acquiree back. And then, of course, management struggles to adapt to the new arrangement. Basically, what we're seeing is that the merger or acquisition often occurs without the foundation for integration being in place. So leadership remains focused on optimizing their historic systems instead of supporting the new business as a whole. Physicians who, frankly, are used to being independent actors anyways, sometimes resist the efforts at migrating to this new, broader organization. And certainly they resist efforts of practice standardization. Often they identify more with their tribe of fellow ologists rather than with the system as a whole. And frontline staff, we find, are very often left in the dark about what the new system as a whole's priorities are. And as a result, they focus instead on local needs and issues over the system-level needs and issues. The figures here on the right are from a report by the Medicare Payment Advisory Commission, sometimes called MedPAC, which was given to Congress last year. You can see $190 billion in excess administrative costs, additional hospital days. But I want to really call your attention to this number about 1 in 3 markets with inpatient occupancy rates under 50%. What these numbers illustrate to us is a key point, which is namely to get better performance out of these new merged larger systems, to achieve the gains that we wanted from consolidation, we have to sometimes make really hard choices like trimming costs or potentially reducing the number of beds. But to do so, you have to fix those fundamentals that are listed on the left. So another way of putting this is that we need to evolve into a community of care instead of continuing to operate in a hospital-centric model like you see there on the left, or a medical group model on the bottom left. We need to move instead towards this community of care model, which is here on the right, where there's shared decision-making. We've got aligned strategies and priorities and common performance expectations and standards, all really aimed at supporting seamless care experience for the patient. Because as I said, if we don't, the patients are going to vote with their feet. And if we're successful, not only will our organizations benefit, but so will the consumer, the patient. See here, affordability, quality, care coordination, predictability could all potentially improve. In other words, the key is to not only protect our margins, but also to build customer loyalty and keep those patients from leaving the area for care. To survive in this new market, provider organizations are going to have to deliver on the promise of consolidation. So what we're calling systemness. So first, you have to actually create tangible system value. You need to figure out how to put all your assets together in a way that delivers something truly different in kind. And this has to go beyond the simple strides towards centralization that we made in the past. This isn't just about centralizing back office functions, although that's certainly a step in the right direction. It's about making hard decisions, consolidating services, scaling back capacity, standardizing quality. And so here I've laid out for you the various stages or degrees of market advantage that you can get from consolidation if you're willing to make the hard choices. And we're trying to show how those choices get harder and harder as you go from left to right on the scale. So operational advantages like centralizing supply chain, they really just require that you recognize and pursue economies of scale. Product advantages, though, that comes from efforts like clinical standardization, and that requires a bit more. People have to work together on a common objective. They have to agree on common care protocols, such as when to use generic drugs or when to use surgery versus physical therapy and lower back pain. Gaining structural advantage may require that you move a service or close a facility. Maybe you need to convert acute care space to an ambulatory surgical center to address that overcapacity issue that I mentioned earlier. Those kind of choices are still harder because somebody's not going to find that a happy choice for them. It may be best for the new system as a whole, the consolidated organization, but it might not be best for them as an individual. And then hardest of all is this last step of achieving transformational advantage, where people have to commit to disruptive change that's really best for the long-term success of the system as a whole. So here I've listed a series of questions for you that are designed to help you kind of plot that course for let's say 2020, 5 years from now. So given the shift from fee-for-service to risk-based reimbursement, what does that mean for your strategy? You need to take this into account. Can you identify a unique advantage for your system in the marketplace and maybe find ways to both demonstrate and communicate value to the consumer? Are you prepared to make those tough choices required to adjust to the new market and leverage all of your organization's resources to the best advantage? So these are some of the key questions for consideration, and there's there's a lot of moving parts here and a lot that's going to continue to change moving forward. But I think the fundamental challenge we face today is not one that's dictated by politics. The key here is to recognize that the problems that the consumer is facing and to solve them. And I think that's really going to be the winning formula going forward. So now I want to move on to the second part of the presentation, where we'll focus on how all this has implications for IT. So first off, I think it's important to understand that the challenges we face in creating these communities of care are not just related to cultural differences or traditional behaviors. Information systems can get in the way as well, and they can create a hindrance to achieving systemness. If the information systems don't integrate, it simply reinforces localized behaviors. So when clinicians enter data in one location and they can't access it in another, when you try to run a report and you don't have data that's apples to apples, when care plans and protocols can't be agreed on across the enterprise, it leads to waste and inefficiencies, things like duplicate tests, unwarranted variations in clinical practices and processes, and therefore increased costs and lower care quality. Exactly the things you need to address in order to thrive in the new marketplace. Now, while it's true that IT can and often does get in the way of systemness, it's also possible to leverage IT to encourage and enable systemness. So starting on the upper left and moving clockwise, IT can provide a baseline for performance measurement, aggregating and sharing data, particularly performance data around the organization as a whole. And doing that is key to identifying those opportunities for standardization and improvement. In the upper right, IT can enforce and encourage the use of standard practices through applications like the electronic health record or some of the tools provided by Formfast. And then continuing on around, IT can provide a platform for care coordination across the system through the use and integration of applications, registries, workflow automation, enhanced communication abilities, mobile solutions. And then lastly, on the lower left, we see tools provided to more actively engage patients in their own care through patient portals and smartphone apps. And so here's our ideal. So people, process, technology, and data put together in such a way that they can act as a single organism, both within the owned and operated as well as with external partners and affiliates across all modalities of care. In this picture, technology is an enabler of seamless care between organizations. And here I'm showing you our IT-enabled survival plan for healthcare organizations in this new market. So a key message of this presentation has been that the market is demanding we do more with less, and IT can help accomplish that through the steps on these following two intensives. So the top row represents the key steps toward enabling systemness and getting the most out of the consolidation occurring in the market. And the second row shows the key steps for protecting and improving your margins. In a minute, I'll show some examples of how to use these intensives, as I call them. But first, let me explain how they work and how they build off of each other. So if you're going to make that shift from holding company to operating company, or if you're going to be successful at integrating partners and affiliates, like we see in the virtually integrated enterprise, you have to start by making communications easy. So relatively simple things, like making it easy to find an email address in the other organization or to find out who's in charge, can make a big difference. In order for the organization to start acting as a single system, we need to make data available, accurate, timely, and comparable. Your data is a foundation for progress towards greater systemness. We need to leverage this data to establish consistent metrics for the system as a whole. So IT needs to not only aggregate the data, but also needs to prepare performance dashboards and to share data and results system-wide so that the best practices can be identified within the organization and replicated to achieve optimal performance by increasing standardization and automation. If you have those factors in place, you can also leverage them to protect and improve your margins. So the bottom row here. First, you do this by using your data to identify your best opportunities for improvement. Then planning your improvement strategies and setting measurable outcome targets. And then reviewing progress on a regular basis and making adjustments if things aren't as progressing as planned. That last step, making adjustments, is often skipped, and it can be a real difference maker, so you want to be sure to include it. So the summary here is to make communication and coordination easy, consolidate data to identify opportunities, establish improvement targets, and define process changes to achieve them, and then don't forget to monitor and adjust. So let's take a look at some examples. The single biggest source of cost savings in most hospitals and health systems is to minimize care variation. Now, we did a survey of chief financial officers not too long ago, and we asked them, where do you see the biggest source of cost saving over the next 5 years, so 2020? This isn't just over the next 18 months, mind you. So we asked them, if I give you 100 pennies, divide the opportunity between them. And to a remarkably consistent degree, with very little variance, they came up with clinical variation. So about 40% of the opportunity at most institutions comes from minimizing care variations. In fact, we've recently done an analysis to look at care variation within health systems, and we found, and this is kind of a shocking number, but it bears out under scrutiny, that the average hospital, if you were to get your care variation down to the level of the best performer at a hospital on clinical quality, just for hips and knees, it would save 1,200 patient days a year on just hips and knees for the average hospital. It gives you an idea of the magnitude of variation that we're talking about. It's enormous. So when we look at the opportunity here, it's really big, but getting visibility as to where your care variation is really difficult. And this is where we need to consolidate and analyze data from across the entire organization so we can identify the fattest opportunities and figure out the practices that we want to standardize on. Once we've identified the areas of focus, we need to have a process to re-engineer the workflow and create scalable standards that can be applied across the entire system. So the key here is that clinical standardization is likely to be the biggest opportunity for doing more with less, and it can help drive, IT can help drive that standardization home through workflow automation. Again, tools like I think you see from Formfast. Now here's another example. This one's from Gunderson Lutheran in Wisconsin. Gunderson determined that poor communication and coordination across caregivers was a critical hindrance to quality improvement and cost reduction. They reconfigured their EHR to streamline workflow and communications across disparate caregivers by creating a new tab in their EHR. Basically, this tab is just an electronic form for centralizing all the information valuable for care coordination. And then they also changed their processes to ensure that caregivers always checked this coordination information first before treating the patient. Another critical factor in lowering costs and increasing quality is to enable caregivers to perform at the top of their license. Our studies of organizations that move into greater risk sharing and into the support of population health and care coordination, particularly organizations that adopt a patient-centered medical home, is that while outcomes improve, labor costs per patient tend to increase. So to counter that, healthcare organizations need to ensure that they give their caregivers that they enable their caregivers to work at the top of their license. And they need to ensure that the work is distributed in new ways between the various caregivers. So this means reconfiguring workflow processes and enabling those changes basically through technology. On this slide, we're depicting an example of how those roles might change and some of the system consequences. You can see the MA, the medical assistant, taking on some new things like performing screenings, reviewing the care gaps prior to the visit, or the care manager creating order sets, or the physician delegating tasks to care manager. These are all things that can be enabled or, frankly, prevented by technology. Likewise, technology can help support the quality committee. With the growth of EHRs today, there's this rapid increase in the amount of data available around quality. But EHRs don't often provide process measures that can help ensure that the processes of care are both effective and as streamlined as possible. So, for example, ask yourself, how long does a patient wait before they see a caregiver? Do you even know the answer? Or how often does an appointment run over its allotted time? What's your no-show rate? Note that these are now becoming quality performance measures. So, for example, the the Boeing ACO requires provider participants to report on these sorts of measures, and it adjusts pay according to performance. So now I'm going to end here, leave you with a set of questions about how IT can be leveraged in your organization to prepare for the future market. Again, I'll target 2020. We suggest that you consider your IT portfolio and ask if it's well positioned to enable and encourage greater systemness, or whether it's acting as a barrier to making those hard choices that the new market's demanding. Ask where your biggest edge is in the marketplace and how IT can help bring that to the forefront. Consider your leadership and your governance structures. Are they in the right place to make progress, using data over gut feeling, for example, to make decisions? Or, as we often find is the case, are you using your data to justify the choices that you've already made by gut feel, rather than to use your data to drive you to the right choice? And lastly, consider how IT can be leveraged to engender greater customer loyalty. So with that, I'm going to end and open it up to questions.
Thanks, Ernie. Like Ernie said, it's time for questions, so we'll field those from the chat or Q&A section. A lot of great information in there about the state of healthcare and some of those changes that we're seeing, that you're seeing, that are impacting all of us. Took some notes as I went through, so a lot of good information to unpack for our users there. One thing I should say, especially for new Formfast users, maybe you're a form designer or work very tactically with the product as an administrator, you may think of Formfast as just the software that stores the forms. Think of us just as a forms company, but we really want to encourage you to think of us as more than that, as an automation platform to streamline processes that are represented by those forms. And once again, especially in tomorrow's section, as we talk more about fast flow, we talk about workflow automation, streamlining administrative processes, then I think that'll become even more clear about how Formfast has evolved into a tool that you can use at in every area of the enterprise to achieve a greater level of automation, a greater level of efficiency, productivity. And that really is in alignment with a lot of things that Ernie shared here. A few things that stood out to me, the $190 billion in excess administrative costs, operational inefficiencies that are prevalent, that are negatively affecting healthcare organizations.
Aaron, the shocking thing about that, I think, is that those numbers tend to roll right off the back of provider organizations. We're so used to hearing these these numbers about huge amounts of waste that we tend to almost write them off and ignore them.
That's a shocking number, and at Formfast, that's what we exist to do, is help you become more automated, to reduce those costs, and more importantly, to help you put more focus back on patient care, to improve the quality of the care that you deliver. And I like the information that you share, Ernie, about the correlation between improving processes and improving care.
Yeah, again, you don't need to invest huge amounts of money in order to make those improvements. The hardest part about it is really around designing new processes. The tools, and again, Formfast it provides many tools that can help with this, but IT has the tools to enable the processes to enforce them. But it doesn't cost a lot these days.
I think that's another big takeaway from your presentation, is that, one, the tools are available. We consider ourselves as a part of those resources. They're available to hospitals to make strides, to work towards a an environment of systemness, as you described, the greater cost efficiency, integration, standardization, and just taking the first step, finding those processes that are not as automated as they should be, whether they're on the clinical side or the administrative side. Once again, areas like HR, risk management, materials management, financial processes, all those in aggregate we feel like add up to a better environment for care delivery and for a more productive healthcare organization. So I want to thank Ernie for his information and for the insights. Once again, this session is being recorded, so you can review that later. I appreciate your time, Ernie.
Yeah, thank you for the opportunity.